Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have our presenters in conference. Please be aware each of your lines is in a listen-only mode. You may submit your questions electronically anytime using the Q&A pod located to the left of your webinar platform. You may also download a copy of today's presentation using the Resources pod located directly below the Q&A pod. It is now my pleasure to introduce today's first presenter, AJ moderator, Robin Begley. Please go ahead.
Thank you for joining us today. My name is Robin Begley, Senior Vice President and Chief Nursing Officer at the American Hospital Association, and I serve as the Chief Executive Officer for the American Organization for Nursing Leadership. I also have the opportunity to lead and champion AHA's Hospitals Against Violence Initiative, or HAV. This initiative focuses on both community violence and violence against the healthcare workforce. This webinar is the first of a series for HAV's new community violence initiative called the Public Health Approach to Gun Violence Prevention. This series will cover topics ranging from gun violence research, mental health and violence, hospital-based violence intervention programs, to community-based solutions for violence prevention. We want this experience to be interactive with our live attendees, so please use the chat box and submit your questions. I will be moderating a Q&A section at the end of the presentation. Today's webinar, Understanding the Biopsychosocial Aspects of Violence Involving Firearms, will describe the biopsychosocial model and apply it to gun violence to identify opportunities for prevention and care. This public health focus will provide hospitals and health systems with strategies for prevention and care to victims of firearms and make the communities we serve safer and healthier. We are delighted to welcome Dr. Steve Hargarten, a professor of emergency medicine, Associate Dean for Global Health, and Director of the Comprehensive Injury Center at the Medical College of Wisconsin. Dr. Hargarten was elected to the Institute of Medicine, now the National Academy of Medicine, in 2011 and is a member of their Global Forum on Violence Prevention. He was the founding president of the Society for the Advancement of Violence and Injury Research and has served on the Violence and Injury Prevention Mentoring Committee for the World Health Organization. He serves on the Community the Community Preventive Services Task Force of the Center for Disease Control and Prevention. Dr. Hargarten's research interests reflect an intersection of injury and violence prevention and health policy to address the burden of this complex biopsychosocial disease. Dr. Hargarten, thank you for hosting today's webinar and providing us with your expertise.
Thanks very much, Robin. Appreciate the introduction. I'm delighted to be part of this important series that's sponsored by the American Hospital Association. I think this is so timely and important for the communities that are served by the various hospital systems across the United States. As Robin indicated, I want to expand on the biopsychosocial aspects of violence involving firearms and really feel this is an opportunity to frame this discussion properly that further informs the subsequent webinars that are being sponsored. I have no relevant disclosures. My brief outline of this discussion is defining the disease model, comparing and contrasting the application of this model to an infectious disease example and apply that to gun violence, frame gun violence as a complex biopsychosocial disease, identify areas, opportunities for prevention and intervention based on this model, and then further identify specific opportunities shown to reduce gun violence that health systems can adopt and consider for implementation. We all know the devastating numbers of patients and families affected by this disease of our modern society. Almost 40,000 deaths, 2/3 suicides, an estimated 100 to 150,000, perhaps as many as 200,000 patients each year not only injured but killed by bullets released from firearms. The disease model has evolved over the many decades, starting in the 1800s when in the late 1870s and 80s the disease model was beginning to be developed. Previous to that, the disease model was behavior-based, one's own fault, was linked to bad smells, evil spirits, and miasma, bad air. All of these were ascribed to how a person or why a person has a disease, and this impaired our scientific understanding of diseases and the development of strategies to treat them and to prevent them. And this is continuing, this search for this continuing identification of the disease model continues to be adopted in modern medicine. As a quote from Jerome Groopman has indicated, modern medicine can be seen as a quest to understand pathogenesis, the biological cause of an illness, and I've added injury. Once pathogenesis, pathos, suffering, and genesis, origin, the origin of suffering, has been established by scientific experiment, accurate diagnosis can be made and targeted therapies developed. So our discussion continues to be relevant today. So the disease process, as outlined by Robert Koch in the 1870s and 80s, requires a cause, an etiology, an infectious agent, coronavirus, as an example. The mechanism of its development is the pathogenesis. What happens when that virus invades a human host? The structural alterations induced in cells, organs of the body. Those are the morphological changes that take place when an individual has a disease process. And following that, the functional consequences of the morphological changes, the clinical significance. That's when a patient presents to the emergency department, to the clinic, with functional consequences from this disease process beginning in their bodies. And so that's helped us frame discussions and understanding of diseases. In the 1800s, malaria, which is Italian for bad air, it was felt that malaria came from bad air. It wasn't understood that this disease process was brought to an individual by a mosquito, a vector, and this vector carried a etiological agent that caused malaria. Two of the four parasites, Vivax, falciparum, are examples of that etiological agent of malaria. There's a pathogenesis to this disease, bloodstream invasion of this parasite with subsequent morphological changes, lysis of cells, and the clinical significance, fever, cerebral edema, organ damage, death. We understand this disease process now with scientific investigations, and we then can address it through treatment modalities or prevention strategies, such as looking at vaccinations or control of mosquitoes, as an example. Our U.S. health systems are superb at addressing and curing diseases like cancer, heart disease, and infectious diseases, and looking in ways in which we can further do that. The biomedical model, building on that scientific disease model in the late 1800s, having been advanced since the early 1900s, the Flexner Report. This has been rigorously applied, leading to longer life expectancy that we're experiencing in the United States. And understanding the behaviors of cellular metabolism and pathological changes resulting in clogged arteries and tumorous growths are advanced by employing biomedical sciences such as physiology and biochemistry. We've made significant strides in this approach to diseases. But understanding firearm violence requires building on these biomedical sciences and broadening our approach to patients injured by the bullet's destructive energy. Applying the biopsychosocial model of illness to gun violence provides health systems with the necessary elements of comprehensive patient-centered care while further informing the public health approach to reduce gun violence. I believe we're at a really critical juncture to really make this effective. So for the disease of injury, the etiological agent is the physical agent, the kinetic energy brought by the bullets released from the firearm. The pathogenesis occurs quickly. The acute exposure to kinetic energy to cells and tissues which are unable to absorb this occurs in a millisecond of an exposure with subsequent morphological changes to cells. Tissues are torn, edema results, bleeding, inflammation, and there's clinical significance that we see presenting to emergency departments and trauma centers across the United States with fractures, hemorrhage, subdural hematomas, shock, and death. So this public health approach to disease, malaria on the left, there's an agent, there's a vector, there's environment, and there's hosts. So it provides, in the disease approach, public health approach, looking at all elements of this disease process to identify opportunities for caring for patients better or preventing the disease from occurring. For gunshot wound, the agent is, again, the physical agent of the bullet. The vector is the gun. The environment are homes, parks, streets, malls, nightclubs, and the hosts are high school students, shoppers, young African Americans, older Caucasians. You see, this framed properly, it informs a public health approach, and it's based on this biopsychosocial model of illness and disease. This model was introduced in 1977 by a psychiatrist in Rochester, New York. It was intended to broaden the approach to patients from a biomedical reductionist approach to a broader psychosocial approach, and it was intended to be broader than those biomedical components that healthcare systems have been so effective in addressing a patient's condition of health that provides opportunities for healthcare systems to do more for their patients and inform public health approaches. Let's take a patient now, a patient coming to the attention of a trauma center here in the United States, in this case in Milwaukee. Here's a notice that occurs in a typical trauma center in the United States. 1 o'clock in the morning, trauma alert. Milwaukee Fire Department Med 7, male unknown age, gunshot wound, multiple back, gluteal area, unresponsive, vital signs present, initial combative, now unresponsive. This trauma alert is broadcasted to a team of physicians, surgeons, emergency physicians, nurses, technicians. The blood bank is notified. The operating room is notified, all with a team approach to address the biology of this disease in a time-sensitive fashion. And this has really made strides in the treatment of the biology of this disease, in many ways saving lives as it's improved over the years. You can see with our index case, we've got a chest X-ray showing the projectiles, the bullets that have transmitted energy to this patient. And so this, again, highlights the needs for addressing the immediate biology of this disease. These are the bullets that are infecting our patients from low caliber, lower mass calibers on the left to higher calibers and higher energy transmissions, if you will, with those bullets that are depicted on the right-hand side. This is an example of a specific type of bullet that was introduced into the civilian market, a black talon bullet. It's a hollow point bullet with razor-sharp talons that can inflict additional harm to the patient. We felt in the civilian market this was an unacceptable virus being introduced to our community. You can see here on this CAT scan, this is the permanent cavity formation across the liver. And this understanding of the biology of this disease helps the surgeon particularly in developing treatment strategies. Perhaps a non-operative management of this patient provides a better outcome rather than subjecting them to a laparotomy and the subsequent complications that may arise from that. So understanding this formation across organ systems helps us develop those better strategies to inform the biological approach to this disease. Here in this X-ray of the humerus, this individual now is looking at a lifelong disability to their upper extremity that's caused by the energy transmission to the humerus. So this disease has a long tail for many patients who are injured in their spinal cord or subsequent fractures such as this that have devastating long-term effects. In this case, again, understanding the energy transmission helps us take care of patients better with understanding that this transmission to the femur was significant. The bullet was shattered, and yet the X-ray looks and appears normal. What we didn't understand was that this significant energy transmission carries the risk of an occult fracture. We did not treat the patient appropriately and subsequently this resulted in a full-blown fracture with its subsequent morbidity. So understanding this biology helps us take care of patients better. How do we understand this biology? We need to go to a laboratory. In this case, the crime laboratory, which we did here in Milwaukee, is really the laboratory for this disease. We don't have laboratories and healthcare systems for this like we do with infectious diseases. So we recruited biomedical engineering from the Medical College and Marquette University to demonstrate that millisecond of energy transfer that has had a very limited inquiry by scientists. And so this .40 caliber bullet is really a good example of the one going through gelatin, which is a good facsimile of human tissue. And we're going to play this video now for you to see the video illustration of this as it's being loaded up. On the left, on the right to left, this is where the bullet's going to come in to these two transducers, and you can see the temporary cavity formation that occurred in the beginning here. Here's continued temporary cavity formation, and through the center here is the permanent cavity formation of this .40 caliber bullet. This is the tissue destruction, if you will, and it depends on the nature of the tissue, lung tissue being more elastic, more forgiving and absorbing that energy versus other solid organs such as liver, brain, where it has limited ability to absorb that energy without damage. You can see that this occurs very, very rapidly, and you can see how the gelatin is disrupted with this energy transfer. Next slide. Sorry. You can see here the permanent cavity formation in a static picture. Here's that permanent cavity a little bit more proximal than distal to the entrance of the gelatin. And now here's the energy transmission measurement. And this is really one of the first times this has happened with a civilian bullet. Higher energy transmission in the proximal portion than in the red line, which is the distal portion over here. So this is important for, again, understanding the biology of this disease. And here's the second video, which we wanted to demonstrate to you from a high-velocity rifle round, a 5.56 NATO. Again, we'll take a moment to have this loaded up. Again, the bullet's going to enter from right to left, same transducers. And notice the difference in the amount of energy transmitted to the gelatin. Imagine this, again, being transmitted to an individual. You can see then the significant temporary cavity formation in the distal portion. The disruption of the gelatin is significantly different than the .40 caliber bullet, which has a greater mass, but not anywhere near the velocity that the rifle round imparts into the patient. You can see a very significant disruption when compared to a .40 caliber. So knowing this, the surgeons know that their planning for tissue damage is more extensive with a rifle projectile than with a handgun. Next slide. Again, here's the permanent cavity formation. Again, more distal than proximal, very different than the .40 caliber. And here's that long permanent cavity formation. And here's the energy transmission measurement. Blue is the first and the red is the second. It was so significant that it actually broke the transducer in the distal measurement. So we feel this is an important quantification of the energy imparted by this rifle round. And it further informs the biology of firearm violence, the tissue crushing and tearing, the subsequent organ disruption, fractures, hemorrhage, shock, and death. This is that biological component of this disease. But then taking that broader approach, as I've started to introduce, the biopsychosocial model, and apply it to firearm violence, this is an opportunity for us to provide a broader real-time care that goes and complements the biological approach to this disease process. So the biology, the social context of the patient, and the psychological, behavioral antecedents and outcomes that affects patients, families, and communities now need to be further considered and applied by healthcare systems. Again, back to our index patient and its subsequent treatment. On the left is that biological component, the physical component, a 24-year-old African-American male, multiple gunshot wounds, multiple injuries resulting in several operations, discharged home. The biological component has been managed. It's stable, There will be subsequent disabilities, subsequent complications perhaps, but that's the biology. But let's look at the psychosocial components. This is a published poet and writer who's been injured from a bullet. He was mistaken for a nephew at a family party, the social context. There are nightmares, flashbacks, hyperarousal, exaggerated startle, poor sleep, elevated pain, fear of retaliation. These are those real-time psychosocial elements of this disease process that need immediate interventions similar to the immediate interventions of a surgeon correcting the biological components. These psychosocial elements can be immediately addressed by health psychologists, social workers that are part of the team's approach to identify early on these sequelae to this injury event and start to manage those behavioral, emotional changes that helps patients fully recover from this event. And it's complicated with families encouraging retaliation to show strength. These are the kinds of things that need to be addressed in real time to both the patients and their families to have a maximal good outcome that doesn't result in more violence or recurrent violence with those patients or their families. Subsequently, this patient had such difficulty that he moved from Milwaukee, and we lost a published poet and writer to our community. So this psychosocial element that complements the biology, the biopsychosocial process, helps us more fully engage with our patients and more fully take care of them in a comprehensive way. So if we look at how health systems, public health approaches to prevent and control firearm violence, again on the right is that disaggregation of the disease, agent, vector, environment, and host. Look at the pre-event opportunities for healthcare systems for screening for risk factors for at-risk groups that we want to identify early on before an event occurs. Perhaps looking at means restriction in some of the vulnerable older adults who are going through transitions, terminal cancers, or loss of a spouse, and they have firearms in the homes. Means restrictions have been looked at and examined extensively. Some healthcare systems are looking at technologies that reduce unauthorized access to firearms. Smart guns is an example. During the event, Kevlar vests for law enforcement are utilized to help manage the kinetic energy from not penetrating into the officer. Magazine capacity, how much energy is appropriate for carrying, is an important quality, an important development that many of us are looking at from an energy standpoint. From post-event, this is where the health systems have been so good at developing systems of care, trauma centers, teams of care to handle the biology of this disease. But now we can look at behavioral screening for post-traumatic stress disorders by health psychologists. Acute behavioral interventions can then be developed alongside the biological interventions, and integrating social and behavioral care, so important for healthcare systems now to more fully integrate into the comprehensive care of injured patients that come to the healthcare systems. It's interesting and of note that the National Academy of Medicine recently released a comprehensive study looking at how health systems can integrate social care in their health systems for the betterment of their patients and their outcomes and the management of healthcare resources. I think trauma-informed care is another opportunity for patients to be treated in a comprehensive, different way, sensitive to their antecedent behavioral issues and their subsequent behavioral challenges from this acute injury event. So there's lots of opportunities for healthcare systems to consider. And I think this is so important for us in understanding this biopsychosocial social aspects of violence involving firearms is that it's science-driven. It's driven by those sciences that advanced our treatment modalities in the biomedical realm. We're now adding other sciences to this comprehensive biopsychosocial model that improves the care of our patients. It pulls in health systems and public health leadership together, along with other sectors of civil society that are so important for us to comprehensively address this challenging issue in our communities. And it informs the prevention and treatment of firearm-related injury. And I think this is really an important element for us to be considering in this series of discussions, is that there's a paradigm shift for research support that's needed. This is a disease of modern 21st century society in the United States. Back in the 1960s, there was a major National Academy of Medicine, National Research Council publication on the neglected disease of modern society that focused on car crashes. And that paradigm shift occurred in the 60s for that problem, and that it resulted in a research support investment that has paid significant dividends as we have seen a steady decline of motor vehicle crash-related deaths and injuries here in the United States. A similar paradigm shift needs to occur for us to tackle this modern disease here in the United States of the 21st century with research support from the NIH. So in summary, and we'll open up for questions, and I look forward to this, George Engel is the author of this biopsychosocial model, and he wrote the seminal article in 1977, The Biopsychosocial Model in the Education of Health Professionals. And as he framed his discussion, and he was looking at health systems and how they utilize the biomedical model, he then summarized his conclusions by saying they meaning us in the healthcare systems, can consider a more comprehensive model that emphasizes psychosocial skills based on systems approach with its potential to enhance collaboration, communication, and complementarity among the various health professions and enhance the general level of competence of each. I think this is what this is the opportunity we have now of integrating this model into the care of the patient who's been injured by a bullet and who's experiencing the biological components and the psychosocial elements of this disease process. It's notable that C. Everett Koop back in 1991 was really building on this model that Dr. Engel had put forth in 1977. I thought this quote was very timely for us to be considering in this discussion. The professions of medicine, nursing, and the health-related social services must come forward and recognize violence as their issue and one that profoundly affects the public health. He is one of the great Surgeon Generals here in the United States, really in the 20th century, and I think this is a quote that we need to take on and embrace and get us involved in the care of these complex patients. Further on this is a recent article in 2017 entitled The Biopsychosocial Model of Illness, a model whose time has come from two researchers from Great Britain, in fact. And their quote, I think, is, again, very applicable to our consideration for today's discussion. Although a biopsychosocial model may not be compatible with the current market-oriented competitive system model with payment for each item, by increasing attention upon the patient as a person and requiring greater collaboration and sharing of care and resources, it will provide a more holistic approach that has the potential to contribute to a more successful and sustainable health system. I think this is really a great summary statement for our discussion today. Finally, I've been, and many others have been thinking about this vexing challenge to our communities, and we need to rethink and frame gun violence in a different way. We need to move away from a false dichotomy debate to a complex disease management and prevention strategy. We need to adopt research-informed public health and health system strategies and treatments. And we need to advance supporting research and get that research supported with resources from the NIH as an example, just like we do with other diseases that adversely affect our communities across the United States. And with this team picture, this is what we do every day in trauma centers across the United States, across healthcare systems, and I feel this is an important quality that has an opportunity to build on a broader model with a biopsychosocial approach to managing these patients in our respective healthcare systems. And I eagerly await discussion of questions and answers from individuals who've been participating in this webinar session. Thank you very much.
Thank you, Dr. Hargarten. Your presentation was really thought-provoking, and to me it illustrated the complexity of this issue. Understanding the totality of the biopsychosocial model as it applies to firearm violence really is critical for us in the field to make inroads in addressing this major public health concern. I really look forward to the questions. We have one in the queue, and I'd like to remind everyone on the line to use the chat box for any questions you may have. So our first question is, are there statutory limitations to applying research models, CDC study, and data collection? Can you discuss those barriers, and have there been changes?
Great question, and I think those are really important. Many have referred to the Dickey Amendment and how that was applied to the CDC back in the 1990s, which really, frankly, had a chilling effect on gun violence research that the CDC was conducting. It was not prohibitive of the CDC to conduct firearm-related research. What the Dickey Amendment addressed was the usage of federal funding, in this case CDC, to advocate for policies specifically using the CDC research funding to advocate for a Senate bill or for some sort of state level policy. That was the prohibitive component of the Dickey Amendment. But what that did do was send a chilling effect through the CDC and through Congress, which was reluctant to advance research monies to address this from a public health perspective and utilizing the biopsychosocial disease model. I think what's encouraging more recently is that in the current federal budget forthcoming, that there are monies being allocated to the CDC and to NIH to research gun violence, and that's a hopeful beginning. That's a beginning that needs to continue and to be built upon, and I think that's really, really important. I think that there are no, from my standpoint, any specific restrictions on gun violence research. Obviously, there are limitations about how we study this disease process, given the nature and scope of how quickly that it evolves, unlike other disease processes that literally unfold in front of us, such as cancer or heart disease. So this has special challenges for us to investigate this, but no less can be addressed in a comprehensive research agenda funded appropriately by federal agencies, including the CDC, NIH, NIJ, and other federal entities. It's notable that several states have funded firearm-related research, most notably California, Washington, and New Jersey. To my understanding, other states are contemplating this. I think this is another example of how leadership across the United States is recognizing the need for firearm injury research and the need to fund it appropriately and rigorously with sound scientific methodologies.
Thank you, Dr. Hargarten. Are there any other questions? We have one coming in. I'll read the question. I'm working on a suicide reduction project based on partnering with gun stores to provide training for staff and their customers about warning signs for suicide. One of the barriers we're finding is that many store owners and staff feel the medical community is against them and has a hidden agenda. What suggestions do you have for reaching out in humility to partner with people who have strong opinions about firearm rights?
Well, that's a really great question and a very timely one, and I think that there are leaders. Kathy Barber from Harvard is a person who knows this area very, very well, and she has worked very, very hard and respectfully with gun store owners to provide a comprehensive approach to addressing firearm violence in communities. What's tragic about this as well is the fact that in many states across the United States, the major cause of firearm death in a state such as Utah, over 80% is due to firearm-related suicides. In Wisconsin, my home state, it's over 70%. And so engaging and respectfully engaging gun owners and gun store owners is extremely important to credibly develop comprehensive strategies to address firearm-related suicide. in California. Dr. Betts has been working with gun owners and others in a comprehensive approach to look at means restriction as a potential for getting patients who are in a behavioral health challenging area to get them through this challenging area so that they can recover and successfully resume their lives. In Utah, Kathy Barber worked with leadership in a bipartisan approach in Utah to bring together different sectors of civil society to work together to develop evidence-based approaches to reducing firearm-related suicides. I think this is an extremely important approach, and culture matters. The culture of firearm ownership is an area that needs to be broadly understood by medical professionals, and it's an urban-rural issue, particularly for firearm suicides. It permeates states across many communities. So pulling in sectors of civil society that are firearm owners and respectfully discussing how we can work together to reduce firearm-related deaths and injuries in our respective communities. A very, very important approach, and I really thank the person who sent in this question. It is so important that be addressed from the beginning. I think AFIRM, which is an organization nationally being recognized more and more, is really doing a lot of this kind of work of reframing the approach that we need to address in the medical community, and partnering with organizations across the United States, such as the 4-H clubs that are in every community, so that we can, again, work together respectfully to reduce firearm-related suicides and homicides in our communities.
Thank you. One more question. Are firearm-related suicides more prevalent in urban or rural communities?
Again, good question. The distribution of firearm-related suicides in states like Wisconsin, that I'm more familiar with, is distributed across the state with higher rates in our northern, more rural communities. The urban firearm-related suicide rates are a little bit lower than the rural rates, but that's the challenge, is that it permeates the entire state, whereas firearm-related homicides tend to be clustered in urban areas of respective states. So that the challenges of developing appropriate community-based strategies to address firearm-related suicides is so important. In Wisconsin, we've employed a systems approach in various counties that have experienced higher firearm-related suicides to address the adolescent population, the mid-age population, and older age groups in focused ways, and develop a systems approach to doing that. We think the veteran population is another vulnerable population, an at-risk population that has higher risks of suicide, and that population is distributed broadly and not limited to large urban areas. So it is really important that each state, each region of the state, understand the epidemiology of a firearm-related suicide so that can be developing evidence-based approaches on a county level, on a more regional level of a respective state. It's really important to recognize how this presents then some very regional specific approaches that are so important to consider, rather than one-size-fits-all approach that may have limitations because it doesn't understand the communities in which this emanates. So great question about that distribution and the important differences.
Thank you. We have one more question. How can healthcare professionals advocate for gun control policy at a legislative level?
Question, I think, is important, but first, to qualify this, I think framing this from our position of strength as a healthcare system is, what are the ways in which we can address this complex biopsychosocial disease with public health strategies that sometimes imply a policy, sometimes imply a program. We do not, and I do not feel that leading with gun control is a way to start the discussion, because that has language baggage, if you will, that I think starts to present an adversarial approach to this, as opposed to injury control, as opposed to reducing the burden of firearm-related deaths in our respective communities. And that's the way I think it's so important for us to start off as healthcare systems. Our healthcare systems are oftentimes led with level 1 trauma centers that are verified on the basis of their research and injury prevention strategies. Sometimes there are policies that help drive a healthcare system, and perhaps a policy on the health system level, it would be that health psychologists are employed now by the level 1 trauma centers for their consideration to, again, more comprehensively approach their treatment of patients, as opposed to a healthcare system asking for policy changes on the legislative level. Would be a policy that would support the treatment of these patients and providing compensation as an outpatient for psychological care of these patients. That would be a great legislative discussion for integrating psychosocial care in healthcare systems by having the legislative body look at ways in which compensation can be provided for the care of these patients. That currently is a little uneven in its approach. So I think that advocating for policy at a legislative level carries with it different layers, an important discussion to have. But again, it's done and can be done and should be done from a public health approach that is comprehensive and sensitive to the wide-ranging communities that each state has and each healthcare systems take care of.
One other question. Dr. Hargarden, do you have any thoughts on, or have you seen best practices around educating the entire team on the biopsychosocial model?
I think it's a great question, and it's in early phases, as we've done in our hospital system at Froedtert Health, and I think it's being discussed at other larger health systems. Kaiser Permanente really was one of in the leading forefront of this, as they co-hosted with the American Hospital Association a workshop at the National Academy of Medicine where the biopsychosocial model was presented. I think that strategy is linked to trauma-informed care, where caregivers are sensitive to the care of the patient and to their own resilience, as Robin outlined in this comprehensive initiative by the American Hospital Association that is as comprehensive in its nature. And I think that is relatively new compared to other initiatives. I think by pulling in some of the specialties, such as physical medicine, rehab, psychiatry, and other specialties that have had a longer history of employing the biopsychosocial model in their practices, would be another step towards a more broader training for healthcare systems to develop so that they can, again, develop this patient-centric approach to taking care of patients.
Thanks. I see one last question. What strategies are being followed or utilized to get groups such as the NRA to evaluate epidemiological data? Any thoughts there?
Well, I think first and foremost, people need to recognize that the NRA was originally organized in the 1870s around two issues, and that's marksmanship and safety. And I think safety is the common ground that we can engage in with NRA leaders in our respective communities, along with other leadership that comes together for common ground, like the previous question about being respectful of gun ownership and the cultural elements of this that are so important in communities across our country. And I think those discussions are important, and recognizing that the disease process is where we know and we understand, we want to gain increased understanding of this so that we can inform our communities in a credible, science-based way that pulls us all in together to address this complexity and to develop strategies to prevent it or to improve the care of the patients, as we've been discussing today.
Seeing no more questions, I'd like to thank you again, Dr. Hargarten, and I'd like to thank all of the participants in today's webinar. This is the first webinar of our upcoming Public Health Approach to Gun Violence Prevention series. You can learn more and register for upcoming webinars at www.aha.org/HAV. Thank you all.
Thank you, ladies and gentlemen. This concludes today's presentation. You may now disconnect.